Even more than that are overweight. And then even more than that are of normal BMI, but skinny fat, low lean body mass, high body fat percentage. And then even more of that.
What about, you made the analogy of, addiction, and there certainly is some overlap there if we're looking at a Venn diagram of eating disorders and obesity and then addiction. There's certainly some overlap between these, but it seems like bulimia would have more overlap with addiction compared to just your standard brand obesity. And bulimics don't have the highest BMI. There's a compensatory behavior there, whether it's excessive exercise or purging.
Mm-hmm.
So I find that interesting that it's not a dose dependent. It's not that people require more and more food over time in bulimia to get the same effect.
Yeah, and bulimia is definitely a binge-related disorder. There's also a general disorder called binge eating disorder. And often when indicated, healthcare providers pick things like bupropion, naltrexone, or even Vyvanse for these indications. But the run-of-the-mill obesity that a lot or even most Americans have, it's pretty close to 50% obesity, and even more than that are overweight, and then even more than that are of normal BMI, but skinny fat, low lean body mass, high body fat percentage, and then even more of that have good metabolic health, which we've defined in previous podcasts, but probably about 10% of people have good metabolic health all in all.
Yeah, I think I've seen studies that say it's like 5% if you're accounting for like existing diseases like hypertension, or someone has known arterial disease, but now they're metabolically healthy. They still don't fall into that healthy category. So I think 5 to 10 is a pretty good estimate. When we talk about addiction in the terms there, like we say someone is an alcoholic or someone is a smoker. What's the difference in saying someone is obese, an obese person, or a person with obesity, PWO, as I've seen it abbreviated in some literature?
Yeah, it's interesting that we keep coming up with these different terms. We used to have morbid obesity and even super morbid obesity. Now we have classes, class 1, class 2, class 3, and that is useful, especially in pediatric obesity. But for adults with obesity, I don't think it's necessarily needed. But the reason why it's often used and why all these terms come up is because of patient-physician rapport. And regardless of the individual, if you're seeing someone with obesity, there's basically a chance that you can lose the connection. And some people say, well, it's just hurt feelings, but it does indeed affect care downstream. And what we do know is that this happens disproportionately in the United States, especially when compared to other countries with low rates of obesity.
Yeah, because there's like the cultural acceptance of something. And if you go back to the way that, I said a smoker, right? Or a person who's addicted to cigarettes. I don't know how we would, like, if we went back to like the 1970s and tried to make some sort of, word salad to not offend smokers. They're still called smokers today, but it was very culturally accepted. You had the Marlboro Man. He was very cool and macho.
He's still cool, by the way.
Still cool, but not up anywhere. And now there's a push for like plus size mannequins. It's very cool and in vogue. And yeah, I mean, anyone can take up exercise and anyone can improve their health at any size. But promoting, that this BMI is like healthy and that this is what health and this is what beauty looks like. That's subjective to each person, but health is more objective. And if you're pushing a cultural norm as something that is objectively unhealthy, I don't see how that's working to solve the problem.
Yeah, I agree. There needs to be a focus on health and metabolic health. And at some point, you just need to have a day of reckoning, but in the way that specific patient can be okay with. And this is different for every individual, because some people come in, and I say a lot of this from personal experience with family and friends, not even just patients. But let's say there's an individual, a female, and she might step on the scale for the first time in a long time and weigh 215 or 220 pounds. And again, yes, this has happened to somebody very close to me, and she could be extremely upset. But this person might have great lifestyle habits, and they might do a DEXA scan and be close to 20% body fat, which is extremely lean for a female. And in that case, then yes, the weight and the scale is just not just worthless, but harmful. But you might have another individual, and they might also be stepping on the scale and think everything is fine. My BMI is 25. I weigh 160 pounds, but do a DEXA scan and come back with a body fat percentage in the above 40%.
Yeah, it certainly could be the case. And I think we spoke a bit about in the past this sort of false protective effect that you might see with elevated BMI in slightly older persons, because those individuals are less likely to be sarcopenic with a high body fat percentage. So it's not that bulking up and adding extra body fat in your 50s and 60s is beneficial to your health, but having some additional lean body mass, which is also captured in the BMI, is useful. And the scale, some people will refuse to weigh. It's can be offensive, and that's, I think, more limited here to the United States. There's not a lot of great data on this. It's hard to get a gauge of what the cultural norms are. But in a study looking at obesity in Japan, which I think is around 4%, relatively low compared to here, only 2% of patients that discussed obesity with their healthcare provider were offended, had a poor reaction.
That were obese, by the way. So that's not 50% of obese patients. That's 2% of obese patients. And that number is well over 50%, I believe 60% in this country.
Yeah, there's not a great, how many people were offended interacting with their doctors when they're obese, but a specific statement here made was over 60% of patients complained that their physicians did not truly understand how difficult it was to be overweight. So to me, that sounds like these individuals were a bit offended, or perhaps at least unsatisfied with their reaction or interaction with their healthcare providers in a discussion surrounding obesity. And that was in the United States. So 30 times more offended by, the topic of weight apparently came up at some point during the visit. And the patient's takeaway was, well, they don't understand.
Yeah. And even if someone is not obese, it does not necessarily mean that they don't understand. And even if they have been in the past, like I've publicly talked about, my large weight change and my loss of 40 pounds of body fat. And obviously, I understand a lot of the lifestyle factors that went into that. I had an unlimited amount of hyperpalatable food. Well, not hyperpalatable, palatable cafeteria foods during residency. Had my first child, and I was also very busy, mostly working night shifts. My sleep was terrible. I was not exercising as much. And although I was eating a very low carb diet with almost no liquid calories, I just enjoyed hyper consuming foods. And one day I just realized, well, I didn't realize, but my wife realized when she was scrolling through pictures, seeing, oh, wow, you used to have abs. And I'm particularly tall and lanky as well. So it was harder to notice even with all that extra weight. But yeah, I stepped on a scale, didn't get a DEXA, wish I had gotten a DEXA, but worked it off with just a lifestyle. So diet and exercise and better sleep too. So I guess I used the 3 pillars, and it was not particularly, I guess it was easy to get to that spot. But once I made that habit change and my habit was set in stone, that in and of itself actually became really fun and rewarding.
Yeah, and I think if people see a little bit of an initial change, right? So something happens in that first month that they're making an effort, they're a lot more likely to continue down that path. So whether they join a gym and they're doing a class with people and getting new social interactions, and there's some novelty to it, or even if someone starts a new supplement, right? Even if the supplement's not particularly effective, there's a lot of scams out there, a lot of supplements that aren't particularly effective, but it's something that gets a person to make a change. It's a catalyst. And then if that person sees results, early on, I think they're more likely to sustain that habit. Whereas if somebody is not putting all the pieces together and maybe all they do is start, walking 20 minutes a day, but they're also eating more calories because they're hungrier, because they're moving more, their energy expenditure is going up.
Mhm.
And maybe they are even recomping a little bit from something like that, right?
Yeah.
But the scale doesn't move. They're going to be quite disappointed, which, I think the DEXA would be a great standard for looking at somebody's body composition. But realistically, when you're looking at a high BMI of 30, I'm not sure I understand the distaste that so many healthcare professionals have for a BMI of 30, because
Yeah.
if you have a BMI of 31, 99% chance that you truly do need to make some changes to improve your long-term health.
Yeah. If you take 100 random people off the street, they all have BMIs from 30 to 35, which a lot of people with BMIs of 30 to 35, they're not even perceived as having too high of weight. Likely none of them will be metabolically healthy. Maybe one if there happens to be a very short elite athlete with a lot of lean body mass, probably on exogenous hormones and PEDs as well. So probably not healthy, but perhaps that one individual is metabolically healthy.